Hello, and very warm welcome to a brand new discussion-based podcast all about antiarrhythmic drugs. I'm Ed Wallett, and I'm joined once again by Stephen Wing.
Hello.
And we're going to be talking about antiarrhythmics. Our last podcast on pleural effusions was quite long. We're going to try and make this a little bit shorter, a little bit more concise, and try and refine the format a bit, I guess.
Indeed, short and snappy is the aim.
Yeah, so let's get on with it. Okay, so we're going to talk about antiarrhythmics. A little bit, I guess, first basic science, which just helps you to understand the mechanisms of these drugs. This is a action potential, which Stephen has kindly agreed to talk us through.
Yeah, so this is an action potential as witnessed in a Purkinje fibre. If you look at other fibres, particularly the ones in the AV node, they'll look very much different. So this is a very fast conducting Purkinje fibre. And as you can see, we've labelled there some phases. There's 1, 2, 3, 4, 5 phases. Phase 0 is a phase termed rapid depolarisation. So if we remember, inside the cell we've got lots of negatively charged proteins, and on the outside of the cell we've got lots of positive ions around. That usually means that the cell's resting potential is around minus 70 millivolts. And when we reach around minus 60 millivolts, we get this rapid depolarization or opening of voltage-gated sodium channels, and then we get this depolarization up to around plus 40.
Yeah, so when it moves from negative to positive, it's depolarization. When it moves the other way, we call it repolarization.
Absolutely, and this is a transient response, and if the membrane is depolarized for around a few milliseconds, then these sodium channels shut. So we get the sort of second phase, which is a partial repolarization, and that's phase 1, that little line that goes back down towards the depolarization.
Yeah.
And this all happens very, very quickly.
Yeah, and then we go on to 2, don't we, which is a sort of, you get partial repolarization and then a plateau. And the main point here is that at this point you've got calcium, which moves into the cells, and potassium, which moves out, and there's a balance, isn't there, between the two?
Absolutely. So there's some calcium inside the cell, already stored within the sarcoplasmic, in the sarcoplasma, and you basically get a small entry of calcium into the cell, and that triggers a very big release of calcium from within inside the cell itself into the cytoplasm. So there's only tiny amounts of calcium going in and out, but the effect is amplified from within the cell.
Yeah.
So you get this inward calcium current, and there's also this the plateau is helped by the conductance to potassium falling slightly when there's a membrane is depolarized. So those two things together give us this nice plateau phase there, number 2.
Yeah, and then moving on to 3, repolarization. This is the movement of potassium, isn't it, out of the cell?
Absolutely, yeah. So the calcium current inactivates and delays this potassium current, and then we get this repolarization occurring in phase 3.
Yeah. And then lastly, moving on to phase 4. Phase 4 is quite interesting because it varies according to the cell type, doesn't it? So some cells you're going to have, indeed cardiac cells themselves, have quite have a completely flat phase 4, and therefore require stimulation in order to push them back into phase 0. Mm-hmm. But these cells, the Purkinje cells, have this spontaneous depolarization or automaticity, essentially, which means that there is a gradual depolarization. So the action potential will fire with or without a stimulus. And if you know anything about ECGs and the nature of Purkinje fibers, and we'll talk a little bit about that in a moment, you'll know that this is actually completely the behavior of the Purkinje fibers and the ventricular conduction system, that if there is no stimulation from above, there is an automatic depolarization, which then fires off and stimulates contraction.
Absolutely. I think the best way to think about phase 4 is that the cells are slightly leaky, and that they gradually depolarize on their own until they hit this level of around minus 60 millivolts, and then you get this, you trigger what's called threshold, and you open all these voltage-gated sodium channels.
And you get another one.
You get another one.
Yeah. Okay, so that's just the basics. It's important to understand that because the drugs relate very much to the specific ion channels that we've spoken about and to the movements of these ions. So this is important to know. So hopefully you'll be familiar with this, basic conduction system. You've got your basic components, your anatomical components, sinoatrial node, atrioventricular node, your bundle of His, which splits into left and right bundles, which then goes out into Purkinje fibers, which supply the ventricular muscle. And you should be just aware of the basic sequence that these are activated in. So you've got sinoatrial node, which is an impulse generator, causes the spreading of electrical activity around the atria, picked up by the AV node, where there is a delay, and then you go out into the bundle of His, and this is the rapid part of the conduction system. Bundle of His, left and right bundles, down to the Purkinje fibers, which then supply the ventricular muscle. And this is reflected very nicely in the ECG, but we're not going to talk about that here. There's other podcasts all about ECG interpretation.
Absolutely. Just to say here, the sinoatrial node acts as the main pacemaker for the heart, because if we go back to what we were saying before, it's the most leaky type of cells. So the sinoatrial nodal cells, they have a greater background conductance to sodium than the rest of the heart, so than the atrial cells themselves and the ventricular cells. So these go up to threshold faster than the rest of the heart and end up governing the pacemaker. So that's why we call sinus rhythm sinus, because it comes from the sinoatrial node.
Yeah.
I think if you understand these two things, if you understand the electrical wiring of the heart and you understand the action potential, it gives you a really good background to go on to looking at some of the drugs.
Yeah, which we will do now.
Yep.
So I think the first thing to say probably, I hope you'll agree, Stephen, is that drugs aren't the only treatment for arrhythmia. And in fact, sometimes they're not very good treatments for arrhythmia. For example, there are other more interventional techniques that are used in certain types of arrhythmias, for example, catheter ablation. In particular, in a condition called Wolff-Parkinson-White, there's you can do ablation of accessory pathways that are key to the pathogenesis of that condition. And also more and more, some of these ablative therapies are being used in conditions that previously we didn't consider to have their origin in accessory pathways. For example, there's a fairly new thing called the Maze procedure, which is used for the treatment of atrial fibrillation.
Yep.
And indeed, they're being used even in atrial tachycardias, flutters, and things like that as well. And I suppose the other thing is ICDs as well, isn't it? So implantable cardiac defibrillators. These have a particular place in the treatment of arrhythmias as well, particularly in the prevention of sudden death that's associated with arrhythmias.
Yep, absolutely. And especially if you've got a very sick patient who's got a tachyarrhythmia, very unwell, and they're compromised, you may think of using electrical cardioversion rather than any chemical agents first, because it's very rapid. Yeah.
So that's important. If you look at the tachycardia algorithms, the arrhythmia algorithms that have been produced by the Resuscitation Council, one of the key steps that you ask yourself when you approach a patient with a tachycardia is, are they stable? Do they have any signs of cardiac instability, low blood pressure, reduced cardiac output, so impaired consciousness level, things like that? And if they do, then you need to act quickly, and the advice is really to act with electrical treatment rather than drug treatment. So I think it's quite useful just to say that before we talk about the antiarrhythmics, just to put it in a bit of context.
Yeah, and something you were saying before the other day when we were thinking about doing this podcast is that all of the antiarrhythmic drugs are pro-arrhythmic in themselves.
Yeah. I mean, that's got to be one of the issues. I mean, and some of them as well have negative effects on the left ventricular output, particularly sort of negatively inotropic effects as well. So these drugs are by no means perfect.
No, not at all.
Yeah, and the classification as well. I mean, the Vaughan-Williams classification is quite an old classification. It's simple. It's fairly easy to use. But one of the problems with it is, first of all, it's a bit of an oversimplification of actually what's going on. And that often you'll find is that specific agents actually overlap into multiple groups. For example, quinidine, which is in class 1, also blocks potassium channels as well, and therefore could be classed as being class 3. Likewise, amiodarone, which is primarily in class 3, also has actions on sodium channels, calcium channels, and the adrenoceptors as well. So it could actually be in all of the groups.
Yeah.
So don't take these classes as absolute.
But it's an absolute exam favourite, isn't it, Ed?
Oh yeah, absolutely. Yeah, absolutely. It's an absolute exam favourite. Yeah. Anyway, should we go through them?
Yeah, let's do it.
So there are 4 classes: class 1, 2, 3, and 4, and the classes correspond with the type of channel or receptor that is blocked by the drug. So from a very basic point of view, class 1 we're talking about sodium channels. Class 2 we're talking about beta adrenoceptors, particularly beta 1 adrenoceptors, which are the main adrenoceptors in the heart. Class 3 we're looking at potassium channels, and class 4 we're talking about calcium channels.
Yep. We've got a little mnemonic, haven't we, Ed?
We have, yeah. There it is.
I like mnemonics.
Mnemonics. Some block potassium channels. It's fairly self-explanatory. I don't think we need to talk through that.
No.
Okay. So do you want to talk through some of the drugs, what they do?
Yeah, we can do. So class 1 agents are split into A, B and C, and this is because they have slightly different properties. The oldest group, class 1A drugs, that are we've got in brackets, they are hardly used. I've never used them, I've never seen them. I don't know about you, Ed, but I've never seen them be used at all.
No,
Yeah.
largely exam-based medical practice, this.
And they prolong the repolarization, and they slow conduction. So they shift the whole action potential, if you like, to the right. And in the theoretical point of view, they dissociate from the receptors sort of intermediately between the B and C agents. But I've never seen these used.
No, neither have I.
Okay.
If we move on to 1B, in this one you've got slowing of conduction, but you've actually got shortening of repolarization. So what this does is it shifts to the left. So while with class 1A you've got right shift of the action potential, class 1B you've got left shift. And then 1C is a sort of neutral shift, I guess you could call it. And that you've got slowing of conduction, but you've got no real effect on repolarization. And actually probably the drug in class C, flecainide, is probably the most clinically relevant of all of these drugs. However, it comes with a couple of important caveats, mainly that, as we said, all antiarrhythmics are fundamentally pro-arrhythmic as well. And flecainide in particular doesn't play well with patients who have pre-existing cardiac disease or left ventricular dysfunction, and actually increases sudden cardiac death in that group of patients. I guess a sort of clinical situation in which it might be used, just to give it some relevance, might be in a young, fit person with atrial fibrillation who has no history of cardiac disease and is otherwise well, as a sort of chemical cardioverter. I've certainly seen it used for that purpose. Class 2 beta blockers. I think we could probably do a whole podcast probably on beta blockers and the various effects that they have. The one that we mentioned here is propranolol. A couple of other ones to be aware of are metoprolol, bisoprolol, perhaps atenolol as well. These have an anti-sympathetic action via the beta adrenoceptor. They're antagonists at the beta adrenoceptors, and they essentially work by slowing AV node conduction through reducing calcium entry into the AV node, and therefore reducing ventricular rate. Clinically, these drugs have particular evidence post-myocardial infarction and in congestive cardiac failure, and often you will see these referenced in that setting. But they are used certainly a lot, and they feature quite heavily in the guidelines. You'll see them used a lot in clinical practice.
Yeah, they do. The way to remember the beta blockers is if you think about the catecholamines, particularly adrenaline, and what that does to the heart. So it increases aortic contraction, it increases the heart rate. The beta blockers will block the sympathetic stimulation of the heart. So they have a negative chronotropic action, so they decrease the rate, they decrease the force of contraction, and negative ionotropic effect. So just think about what the adrenaline would do to the heart, and the beta blockers do the opposite. They block the sympathetic activity. So class 3 agents are a bit of a weird group, really, and I think this was put in the classification because there was this drug amiodarone and has lots of different effects on the heart, and they do block potassium channels, but they do lots of other stuff as well. That's probably too much detail to go on here. So amiodarone now is considered as cardiac domestos. It will kill all known arrhythmias and is used a lot, very in acute situations in lots of cardiac wards around the country.
Yeah.
But it does have particular properties in that it is bound to tissues very, very heavily. It's fat soluble, so you often require a loading dose, and because it's very irritant to veins, it needs to go through a very large central vein. So patients often have to have a central line to have the loading dose put in.
Yeah, and
it has
some very important side effects as well. Side effects that you will hear a lot about in exams, particular exam favourite. I mean, it affects all systems, but I mean the main ones are thyroid dysfunction. So these patients need baseline thyroid function tests, and they need follow-up thyroid function tests. Pulmonary fibrosis is another one. Corneal deposits and slate grey appearance to the skin is the other favourite as well. I think four's probably enough to remember.
4 is enough. There's a new drug on the scene now. I don't know if we're starting to hear a bit more about it, called dronedarone, which is kind of like, because amiodarone is hated by everybody. It's hated by the endocrinologists. It's hated by the respiratory physicians because of all the side effects Ed described. And this new drug doesn't contain iodine, so it's got a slightly different side effect profile, but is not as good acutely. So that's sort of coming on the scene now.
Yeah, and I guess we should say with flecainide we wouldn't use it in patients who had a particular history or known cardiac disease, but amiodarone we could use.
Yeah, we could.
Yeah, and that's often the setting which you'll see it used quite a lot, as in on the acute cardiac units where it's needed in patients who have cardiac disease, and you'll certainly see it used a lot more than flecainide. Going on to class 4, these are the calcium blockers, which are split into 2 groups. The dihydropyridines and the non-dihydropyridines. I
always get them mixed up.
Yeah, do you remember the way around they go?
Yeah, so it's the non-dihydropyridines, I think, that are the rate-limiting calcium channel blockers, the ones that would appear in the Vaughan-William classification for cardiac dysrhythmias, but the dihydropyridine ones are the ones you're going to be using for hypertension and all the rest of the things.
Yeah, exactly. So the 2 key ones here are verapamil and diltiazem.
Absolutely.
Cool. So, I mean, we've just had a sort of run through of the Vaughan-Williams classification. Once again, I think it's important to say that this isn't the complete picture. It's a good classification. It relates the drugs to their mechanism of action and provides a framework for memorizing them. But there are lots of drugs that you will come across that are used for the treatment of arrhythmias that aren't in this classification at all. So this slide briefly is just to illustrate some of those and some of their uses. Do you want to talk through this, Stephen?
Yeah, so atropine is sort of the principal agent, the first thing we use when someone has a bradyarrhythmia and they're compromised by it. So this is in the Resus Council guidelines, and we give atropine, and it blocks the parasympathetic nervous system, blocks the vagal tone, and is supposed to increase heart rate.
Yeah.
Isoprenaline does this by stimulating the myocardium directly, so that's something that we used to use, but not. I think it disappeared for some reason. Apparently people couldn't get a hold of it for no particular reason, I'm told, but I think it's starting to reappear again.
Yeah, I mean, I personally haven't used it or seen it used very much, not when compared to atropine. I mean, atropine is really used quite a lot.
Yeah. And adrenaline is something we use at the moment for people who are in cardiac arrest to as a bit of a vasopressor and to increase the cardiac output. And we use that for people who have been down a long time in a shockable rhythm, but particularly for those who are in a non-shockable rhythm, a PEA with a slow heart rate or asystole.
Yeah.
So digoxin, the cardiac glycoside, this is one of your favourites, isn't it, Ed?
Oh, I love digoxin, mainly because of its historical significance,
Yeah.
foxglove and the like. But digoxin it used to be used for the treatment actually of heart failure because it was thought to have positive inotropic effects. But actually now all the evidence says is that it really should mostly or only really be used for rate control of atrial fibrillation in patients with congestive cardiac failure. That's the sort of combination that you need to remember. Think AF plus heart failure, rate control, digoxin.
Yeah, because we were saying before that the beta blockers have kind of taken that prognostic sort of window away from digoxin a little bit.
Yeah.
And digoxin, surprisingly, is now not in the new guidance for treatment of acute AF, so it's not even in there as one of the first-line agents you should consider.
No, but you still see a lot of patients on it.
You do. It's more commonly used. I think because it's just been around for hundreds of years, people are very familiar with it.
Yeah.
It's a good drug.
Good drug. Adenosine is next. Adenosine is another drug that features quite heavily in the Resuscitation Council guidelines, particularly for the termination of supraventricular tachycardias. So that's your tachycardias, your AV reentrant, your AV non-reentrant tachycardias. It's typically used in an emergency setting, usually for patients. Typically, I've seen it most often used in young patients with supraventricular tachycardias who are hemodynamically stable, and we want to stop the arrhythmia.
It does work. It works very well. I've seen it work a number of times, and often people try vagal manoeuvres first, like blowing into a big syringe or carotid sinus massage, and they never work. I've seen it work maybe once. It's always great when it does, and then we get the adenosine out for a supraventricular tachycardia, and as Ed said, it's very horrible. It can give people a feeling of impending doom and a tight chest, and shouldn't be used in asthmatics.
No, don't use. What would you use instead?
For asthmatics, again, you're not going to consider a beta blocker. Amiodarone's a favourite, really, for me.
Yeah. I think you'd have to.
Quite
use
difficult.
That, yeah. And then the final one, calcium chloride, used quite a lot, particularly in association with dysrhythmias associated with hyperkalemia. And that's mainly because the calcium has a cardioprotective effect to the elevated level of potassium, which is very arrhythmogenic. You'll typically see calcium gluconate used more commonly, actually, for the sort of routine management of hyperkalemia as a cardioprotective agent. But calcium chloride is more indicated, actually, in the acute setting where there's a dysrhythmia that is associated with hyperkalemia.
Yeah, exactly right. So it's calcium chloride, the one that you see on the trolley, the cardiac arrest trolleys, isn't it?
Yeah.
And I think it has a faster duration of action. Contains probably a bit less calcium, so you might need to repeat it. So I think people generally prefer to give calcium gluconate because you don't need to give it as often, and it's a slower, longer duration of action.
Yeah.
Good.
So that's pretty much it. We've had a look at antiarrhythmic drugs in this podcast. We've looked at the action potential, in particular focusing on the important phases that correspond with the various classes of drugs in the Vaughan-Williams classification. We've recapped the conduction system of the heart, and we've spoken in a fair bit of detail about each drug in the classification, its particular class, what it does, and some of its clinical uses. And then finally, we've spoken a little bit about drugs that aren't in the Vaughan-Williams classification, but that it's important to know about.
Mm-hmm.
So that's it. Anything else?
That's it.
That's it.
No, thank you very much.
Yeah, thanks. See you again soon.
Bye-bye.